The 45-year-old man can have a prostate, that's all. Sorry, I had to run to be on time. No disclosures. Here's the waiting room of a urologist at the time that I entered urology. And that time, life was simple. All those men were diagnosed to have prostatism, and they got surgery. Then there was a publication that changed the world of urology. It was April 79, and suddenly there was a difference between not all men are identical, not all men got the diagnosis prostatism. I'm sorry. So here are all the men at that time. And you can see they are similar, but they are also different. What's the similarity? They are all wearing a hat. And what's inside the hat? They are referred to secondary care. And primary physicians who saw them, in general, are very good in some things. They are good in diagnosis. They are good in pathophysiology. And they are good in management. You have to change the way of life. And they are very good in that. In a large percentage of patients, this helps. And this keeps the patients out of secondary care. But some remain worrying. Some of those men are not happy with the situation, not happy with the care of the primary physician, and they want further diagnosis and further treatment. They are referred to the medical specialist. So what's inside their head? The symptoms or the bother have persisted or are worsened after the initial management established by the GP or the primary physician on the basis of symptoms and signs. So they come into the hospital, which is full of machinery and full of labs. And a man like you and me, sorry ladies, if you can't measure it, you can't handle it. Men come into the hospital for objective assessment of dysfunction. So all these men, they are not the same, they are similar. We have disease concepts for these men since April 79. And they can have various combinations of dysfunctions, all leading to the same set of symptoms, all having a history of prior management by the GP on the basis of the symptoms. So since 91, there is a standard of analyzing pressure and flow, and it says that we do a pressure flow analysis. I concentrate on the pressure flow analysis of 2,500 men over 45 years of age. Some have a big prostate, some not. Some have many symptoms, many not. But all are referred to the GP, by the GP. If you see increasing grade of obstruction, decreasing strength of the truther contraction, and increasing numbers, you can see the columns in the various classes and grades and stages of their disease. Of all men referred with symptoms and flow rate available, there's free flow rate and then pressure flow. Free flow rate, they had 30% had bladder outflow obstruction grade 3 or higher. And that would be an indication for management if the patient wants it. Can be medical, can be surgery. Patients with a flow rate above 14 mL per second rarely have bladder outflow obstruction. It's 15%. And it's virtually never high-graded. You can see on the left side that it's about 15 patients having high-grade bladder outflow obstruction. Patients with a flow rate below 10 have a 40% chance of having bladder outflow obstruction, but also a 40% chance of having detrusor underactivity as their primary diagnosis. It's the blue columns. They have, at the left side, low grade of bladder outflow obstruction and a relatively weak contraction. So, and patients in the middle, they are basically in the middle. Again, I'm excused. This is rather randomly divided in the middle. So, prostate size would help a bit, since a patient with a larger prostate has a slightly higher likelihood of bladder outflow obstruction. But that is only off topic. So if you take grade 4 as a threshold to advise surgical DAS obstruction, you would operate only on 3% of all referred patients. If you take grade 3 as a threshold, you would operate on 15% of the patients. Based on urodynamics, you could save the surgery for many of your men. What I want to you to take home is that of all patients referred, 30% have bladder obstruction grade 3 or higher. And that is bladder outflow obstruction according to ICS definition. Patients with a flow rate above 14 rarely have bladder outflow obstruction and never high grade. There's never any danger in these patients to go in retention within short period. And if the flow rate is lower, 30 is the average for bladder outflow and or underactive detrusor contraction. So if grade 4 is taken as a threshold, you would operate only a very limited amount of patients, and grade 3 somewhat more. Without surgery, 71% would profit from conservative measurement based on urodynamics, and they know what they have and they can accept it without much further. So it's a feedback for their function, the urodynamic. They understand what we are doing, and then they take it as a feedback and as a reconfirmation. 50% of the men without bladder outlet obstruction has underactive detrusor as the cause for their dysfunction. And basically we have no specific treatment, and that's a regret. A proportion of men will have storage dysfunction, which is not included in this diagnosis, but we have in this talk. But we have specific treatment for that, and they could continue and start with specific and evidence-based medical treatment without surgery. So, if you stratify disease, you go from general to specific, and this article has helped us in this. So here's the conclusion. Staging and grading is a condition sine qua non for medical specialist management, and I said it would reduce surgery. I thank you for the attention.
Thank you very much. Do we have questions from the audience? We have time for 2 or 3 questions. If you'd like to state your name, Dr. Yandi, and where you come from.
Dr. Yandi from Pune, India. Interesting, Dr. Rosier. You have in your presentation stratifying bladder outlet obstruction on one side and detrusor underactivity on other side. Now, my question to you is, why do you distinguish in the two? Couldn't there be a combination of both? That's number one. And if that is the case, what would be your criteria of offering surgical treatment to these patients who have detrusor underactivity and bladder outlet obstruction together?
Okay. 2 questions. You gave me that. Of course, there's a combination of detrusor underactivity and bladder outflow obstruction in a proportion of patients, and I said 30. So the 30% has about the thing is detrusor underactivity without significant bladder outflow obstruction, and then the group in the middle with the combination, and then the severe bladder outflow obstruction. So that's yes, there is a combination, of course. And how to stratify management? That's the sad thing is that I can tell you what I would think, what was good for my patients. The sad thing is that since 1979 we do not have good evidence to show for the cohorts of patients that I show you that what is the optimal treatment on the basis of this stratification. And of course, I have my own database, and I will have the opportunity to present the outcome of our institute based on this stratification maybe in a few months. But I want to address that stratification is important, like radiographic stratification and the imaging in all kinds of diseases. So if we forget the stratification, then we will never get an answer to your question. So we should start with stratifying and then see what the outcome is in those cohorts with the differences that they have. And of course, we should do face valid management and then test that.
Thank you very much. I was interested that only 30% of your men had level 3 or greater obstruction. Can you just remind the audience who are perhaps more used to using the ICS nomogram what level 3 is?
Oh, it compares with grade 40, BUI 40. So that compares with that bladder outflow obstruction index.
And what was the average age, the mean age of your population? They were 45 or over?
I think 64.6.
Right. Because it's certainly,
like that.
You have a lower proportion of obstructed patients than we see.
Yeah, might be the threshold for
older.
referral, and I'm not sure. But yeah, I think I expect a question about symptoms, and I'm happy that there was not a question about symptoms. But if you see all the studies, all the patients recruited and included have an average symptom score of 17, which is exactly the average symptom score of my set of patients. So it's not the symptoms that makes the referral. But I do not know whether the difference in grade of obstruction is different. But even there's not much evidence. We do not have much clinics showing this clinical epidemiology. So the lack of data is one of the conclusions.
Okay. Thank you very much, Peter.